people and checked in our repository as to whose samples was available, we could actually get 5 FTA cards which were collected of these individuals a little some years back. And but then it was but the count was 9 or 10. So then what else should we do? So then apart from that, there was a huge exercise which was undertaken of identifying the relatives. Where exactly were they? Thanks to the uh, in fact support and effort of the then DGMS, we actually could facilitate the nursing assistants of the local units visiting these individuals, the next of kin, and collecting the blood samples primarily of the children, in case not available, then of the parents, and even if in case if they were not available, we went around collecting the samples of the relatives also, of the brothers also, the siblings. And you can see in just a matter of about a day, this whole exercise was undertaken very effectively. In fact, the DGMS Air personally facilitated the availability of the aircrafts also. And as you can see, the samples then they actually, as what is being seen in the red, is the blood samples collected from the relatives were moved to Delhi, and we also in the interim had found those 5 FTA cards which were moved from AFMC at that point in time to CTFD Hyderabad. And here we had the the tissue samples which were there, which were the test samples. They were flown in from there to CTFD Hyderabad. So here, in fact, my colleague, the then colleague, Colonel Sandeep, was in fact processing these blood samples. We didn't want to take a chance because these are so preciously and very effortfully collected blood samples. So we wanted to take wanted to keep two sets of them. One, we had it in a EDTA tube, preserved in a cold chain. Another was that we transferred them on a FTA card also, so that they could be transported at room temperature. And then subsequently, so we can here see the list of, it's around 17 individuals all across the country that these samples were collected. And uh, then subsequently, these samples were transferred, as I had said earlier, to CTFD Hyderabad. The time when these samples were being processed at CTFD Hyderabad, we undertook another massive exercise, which was of contacting the next of kin, requesting in case if someone was available in the vicinity of Delhi to be there, or in case not, then the buddies or the officers belonging to those individuals units were also requested to be available, and at suitable place an personal interview was undertaken with them to collect at maximum antemortem data. And in fact, to the extent that we even went on to the point of contacting on video call to the relatives also in that exercise. The criticality is that as much data that you have, especially of the antemortem, which we can actually then subsequently, while we are examining the body, we can correlate it with some kind of an antemortem artifact or something that we are detecting on the body. And one very remarkable thing which actually pinpoints to the importance of forensic radiology was of the CT scan which was undertaken at MH Wellington, identified that in one of the bodies there was some kind of a defect seen in the grade 2. And when we took a history from the relatives, one individual was identified to be having a previous fracture which was malunited. Just coming on to the DNA fingerprinting aspect of it, basically the non-coding, the nonsense region of the DNA is what holds the key to it. And of that also, a very small part, which actually is called a short tandem repeat. I would say that like this set of nucleotides which is there of GATA, each and every one of us has this particular sequence of nucleotide. All those sitting in this particular hall have this particular set of nucleotide repeating itself. The way we differ amongst each other is the number of time it repeats in us. So on the various chromosomes. And this is actually the various short tandem repeats earlier on brought out by the FBI called CODIS, which are located on the various chromosomes as are highlighted here. And this is what actually is looked for whenever we're doing a DNA profiling. So just a very simple process of extracting the DNA, quantifying it, amplifying it, and then generating a DNA profile from it, which actually would look like this. So what we are seeing here is in this particular section is actually one of the STRs, and these two peaks that we are seeing, 16 and 17, as you are seeing here, is actually the number of time that particular STR is, or the nucleotide sequence is repeating in itself. Here we are seeing just one because actually it's a homologous allele available on that particular set of chromosomes. So finally, when the DNA profile was generated by the CDFD, we got this report. And as you can very well see here, which I will enlarge here. All these were the numbers given to the bodies which were there, which we had seen, and these were the relatives with which it matched. And in fact, here you can see that it matched with the blood sample also. One very unique case had happened, that the tissue was destroyed to that extent, and secondly, the aviation fuel itself is very critically limits the amplification of the DNA. So one profile could not be generated completely, and that profile was identified by exclusion, since it did not belong to anyone. And that's why I had specified that it was actually a close disaster, close accident. So, and there was no ground casualty, luckily, in that case. We could very well, after having looked at the DNA profile report, which actually was provided to us personally by Dr. Thangraj, the then head of the CDFD Hyderabad, and was discussed in-house at the directorate, looking into the antemortem and the postmortem data also. And that's when it was finally it was disclosed that all individuals were positively identified, and then they were humbly handed over to the units and the relatives for their final journey. And it would not have been possible without the real-time help of Brigadier Varghese sir also, who actually was heading the unit, MH Wellington, at that point of time. With that, I come to the end of my presentation.
So it was a sad situation, and my compliments to the team for successfully conducting this whole noble exercise. So if there is any question, so we can ask a few questions if it is there. Fine. So if there is no more questions, thanks a lot once again. So now I request Colonel Anurodh Gupta, HOD Department of Biochemistry, to enlighten us on the next generation sequencing, which is a transformative technology that has revolutionized genomics and enabling us for rapid and high throughput sequencing of DNAs and RNAs, allowing for the simultaneous sequencing of millions of fragments. And it provides an unprecedented depth of data and insights. So, Colonel Anurodh, please.
Good afternoon, sir. Thank you for the introduction. Not the HOD biochemistry anymore. So today, what has changed in cancer management over the last 10 years? If a patient was diagnosed with lung cancer 10 years ago, the 5-year survivability would be somewhere dismal to 5 to 7%. But today it stands at 80 plus 80%. And this change has come because of something which we know as precision oncology therapy. And this precision oncology basically means that we tailor make the treatment or the therapeutics to each patient. And the backbone of this precision oncology is next generation sequencing. We started NGS at AFMC in end 23, and initially we were doing only whole exome sequencing and HLA typing. We've done more than 600 whole exome sequencings, but around 1.5 months back, we started venturing into oncology, and we've received certain NGS panels which we can use for oncology. So this is the overview of my talk today. Solid organ multi-cancer panel. Now, the aim of today's presentation is to sensitize the audience about the panels that we have. A panel is essentially a group of genes that are related to the cancer type, and it somehow gives us information about what drugs the cancer is sensitive to, what is likely to be the prognosis of the patient, and what combination of drugs can be used. So this is a panel that we have. It is a solid organ multi-cancer panel. So it is, instead of going for individual cancer panels, we have selected a panel which can be applied to a large number of malignancies, because we are unlikely to get 20 breast carcinoma cases in 10 days. We are expecting multiple cancers, and that is why we have gone for a panel which covers multiple mutations of multiple malignancies. So this panel detects somatic mutations in solid organ cancers, and we use tissue from fresh frozen tissue or formalin fixed paraffin embedded blocks. The panel detects DNA hotspot regions. Hotspot regions are regions which are recurrent mutations or have been documented to have mutations repeatedly. So this panel consists of DNA of 60 genes, which is shown in the list here, and the CNV, that is the copy number variations, RNA fusions in 29 driver genes, which is shown here. So this is the list of genes that is covered, And the panels or the cancers in which these can be applied are lung, GI, melanoma, carcinoma of unknown primary, and all CNS tumors except medulloblastoma. So if you have a patient who's diagnosed with any of these malignancies, his fresh frozen tissue or FFPE blocks can be sent to us. The next panel that we have is the comprehensive genomic profiling. Now, comprehensive genomic profiling is usually used for medulloblastomas, gallbladder carcinomas, pancreaticobiliary tumors, recurrent colonic carcinomas, or rare tumors. This is a very extensive panel which gives us information about 523 genes. It gives us information about copy number variations in genes, about tumor mutational burden. Now, all of us have some number of mutations per MB of data or per MB of genome. But when the number of mutations are more than 10, that is called as high TMB, that is tumor mutational burden is high. So this makes patient cancer sensitive to certain drugs. The third variable is the MSI, that is microsatellite instability. It is also an indication of the number of mutations that are present in that tumor tissue. And HRD is homologous recombinant deficiency. That is, there is a defect in the DNA repair mechanism. So all this information is given by this panel. And HRD specifically is useful in cancers of prostate, breast, ovarian, and pancreatic cancers, because that HRD defect is now sensitive to certain drugs such as olaparib. The third panel that we have is the hereditary cancer panel or hereditary breast and ovarian cancer panel. So HBOC panel specifically tests for mutations in BRCA1 and BRCA2 genes. We must remember that these mutations are germline mutations that predispose individuals to develop these cancers at an early age. So usually they are indicated in patients with strong family history. The HCP panel, that is the hereditary cancer panel, covers all the genes that are that are implicated in these syndromes, these hereditary cancer syndromes. So this is both of them can be done on blood samples. The fourth sample that we have is a myeloid NGS panel. This covers 49 gene variants and is indicated in myeloid leukemia, MDS, JMML, or myeloproliferative neoplasms. And here also we can take 3 ml blood or bone marrow sample. So this is the summary of all the oncology panels that we have as of now. The cancer hotspot and the oncology 500, these two panels work on FFPE tissue. The myeloid works on peripheral blood, and HBOC also is used for peripheral blood. Now, what are the issues that we face, especially when the biopsy of these tumors is either a CT guided or a very small core biopsy? Then I request my intervention radiology colleagues to please take out one more extra core for molecular testing, because frequently when we receive these FFPE blocks, there is really no tissue left in this. And advice to my pathology colleagues is that if these cores can be processed separately, and we must use 10% neutral preferred formalin in this, because the processing of these tissues damages the DNA. So if you use 10% neutral preferred formalin, the